Sandy. Let's see, can you hear me?
Yep.
Okay. Thank you so much for that kind invitation and good afternoon. I imagine that most of you are here because either you have headaches, some form of headache, or you know someone who has headache and are here for more information. My goal today is to educate you about headaches and migraines and help you get better control and learn more about these disorders. I'm going to start first of an overview of headache, just talking about what we mean by the term headache, and then we're going to focus on migraine, and we're going to focus on how do we define migraine, what are the mechanisms of migraine, in other words, why do people get migraines, what's happening in the brain when that happens, and then we're going to talk about how to get control of these beasts, lifestyle management, how we treat them acutely when you're in an attack, what preventative treatments are available, complementary approaches. And then I want to just briefly touch on worrisome headaches, signs and symptoms that should alert you to it may be more than a migraine and you need more emergency care or urgent care. And then we'll wrap up and take any questions. So what is a headache? Headache isn't a diagnosis, it's actually a symptom in the same way that if you had a stomach ache, it wouldn't give you the diagnosis of what was causing the pain. And in fact, a large percentage of the population experiences headaches. Almost 50% globally of adults have headaches in the last year. And we define these using the criteria laid out by the International Headache Society, who developed the International Classification of Headache Disorders a few decades ago. And this classification system allows us to divide headaches based on symptoms and studies, and divides them into something called primary headaches, which is what most people get. Things like migraine, tension type headache, cluster headache. You had mentioned some other headache disorders that are considered primary headaches. And then there are the headache types that are called secondary. Those are less common, but usually what people are concerned about because they can have serious effects on your well-being, things like brain tumors, aneurysms, infections. And then lastly, in the group of headache disorders are called cranial or focal or facial neuropathies, when people have nerve impingements that are causing pain. First I'm going to ask, just going to talk about what's the most common type of headache disorder. Tension type headache. It affects about 78% of the population. Migraine affects about 16%. That is more common than asthma and diabetes combined, although many people find the topic mysterious and many people go undiagnosed. Does anybody here know what the most common secondary headache type is? Any takers for the question? It's actually hangover headache is the most common secondary headache, affecting about 72% of people in their life will sometimes have a hangover headache. And then followed by that is nose and sinus headaches, things caused by infections or structural problems within the sinuses and the nasal cavity. The things that we worry about, such as non-vascular intracranial disease, that means stroke, brain tumors, and so forth, affect less than 1% of the population, and head trauma accounts for 4%. Let's go into defining what migraine is, because the reason it's important to come up with a diagnosis is because the diagnosis is what triggers treatment. How we're going to treat you is based on what you have. And although people experience migraine differently, there are specific features to migraine. You'll see on the right-hand side of the screen there, I've put up some information about tension type headache, and it's mostly to compare these two. A lot of people think that if they don't have a severe, awful headache that's driving them under the covers, that it must be a tension type headache, but rather there's sort of a spectrum of pain that people can experience with migraine. And we think about migraine as being a feature full disorder, and tension type headache not having the features that really typify migraine. So migraine headache has to have, in its main features, 2 out of 4 pain characteristics, and that's one-sided, throbbing, which is what often people think of as migraine, Moderate to severe intensity, so what does that mean? On a 1 to 10 scale, ranging somewhere between 4 and 10 out of 10. And worse with activity, meaning that when you experience the pain, you'd rather not exert yourself. You'd rather be still, or you might even be prompted to lay down, or you may avoid activities. And then accompanied by this pain, you need to have at least one of these characteristics. That's either light and sound sensitivity, or a person may experience nausea or even vomiting. These symptoms vary in intensity from people just preferring something a little bit dimmer and quieter and not really realizing it until the lights are dim, to being extremely severe where a person needs to shut down and be in a dark and quiet place. And nausea itself can sometimes just present as a symptom as a disinterest in eating. A drop in appetite is really part of the same process of what's going on in the body when people experience migraine, which is actually a slowed down gut transit time. Migraines typically last 4 to 72 hours untreated, and then it's an episodic disorder, meaning a person experiences the headache and the pain and the associated symptoms. They go through that, and then they're well on the other side again. In order to make the diagnosis, a person has to have at least 5 attacks, and it assumes that it's not caused by some of the secondary problems that we discussed. Tension type headache, by contrast, is typically a mild to moderate headache that's pressure-like. It does not reach the intensity. It typically doesn't throb. People typically can go about their everyday activities. Some people may have a little bit of light sensitivity, but often it doesn't interfere with activities. In my practice, I have very few people who come to me for tension type headache. If they're coming to see a doctor, it's usually because the pain is interrupting their activities. So I have patients with migraine who have tension type headaches, but it's only the people who have tension headaches every day or chronically or worried that it's something else that come to see me. I have done on the bottom, you'll see something called sinus headache. It's a common misdiagnosis. People with sinus headache, you'll notice in our symptoms of migraine, I don't say where in the head that is, so a person could have a bilateral, meaning two-sided headache that's pressure-like, but if it's moderate and worse with activity and associated with those symptoms, it may actually be migraine, even though it may be in the sinus areas. So typically, sinus headaches are associated with sinus infections, things like perhaps you have a fever or symptoms of a upper respiratory infection or green nasal discharge, and there's not this history of these recurrent episodes. There was a study done looking at 300 people who were diagnosed with sinus headaches, and of them, when they were re-examined by neurologists, actually 90% were misdiagnosed and in fact had migraine. So something to think about if you're getting recurrent headaches, even if they're in this area. I want to talk about migraine. We think about migraine with and without aura. Some people have heard about the term aura. About 30% of people with migraine also experience migraine with aura, so those people may get with or without aura. And that are these reversible neurological symptoms that can begin either at the start of the headache pain or often before the headache pain, and the headache starts as the symptoms start to fade. These symptoms typically last 5 to 60 minutes, usually are of gradual onset and then gradually fade away, and include difficulty with vision. You'll see in the upper right-hand corner, you'll see up here, we have a picture, a cartoon sort of what a migraine aura looks like. I actually have a video on the next page, so you can sort of experience one yourself by video. Some people get speech disruption where they can't get the words out, or the words come out all confused. You may have seen a news reporter a number of years ago who was speaking while she was reporting, and all the words were coming out jumbled. It sounded almost like a stroke. In the end, it turned out that she had migraine. Some people also get numbness or tingling. And then there's a less common migraine aura, which is called hemiplegia, where a person gets stroke-like symptoms, where they can't move an arm or a leg, and then it's recurrent. That's often a familial disorder. Of the rarer aura types is something called Alice in Wonderland syndrome. It's extremely uncommon, but it was thought that Lewis Carroll had migraine with aura and experienced this type of aura, which prompted him to include those features in The Adventures of Alice, where she feels really, really tall or has this very small feeling. That's how these people experience their auras. It's sort of a distortion of their experience of body in space. Again, when people have these, they're different than a stroke because they're fully reversible. Things like stroke need to be ruled out if it's the first time experiencing them, and they have different symptoms. Let's see. I'm going to play this video. I hope it plays. Oh, no. It's not going to play. I'm sorry.
I'm
yes.
sorry.
I'm terribly sorry. It looks like this didn't load with the video aspect of it, but I'll describe to you what a visual aura typically looks like. If I were talking to you and I were experiencing a visual aura, I might start noticing a blind spot in my visual field, and I might look at you and see that part of your face might be missing, and that would start to expand, where larger parts of my visual field would disappear, and I would develop some shiny lights and zigzag lights that would happen in the periphery, and then over 5, 10, 15 minutes that would start to fade. It would be in both of my eyes. It would subside, and then I would experience a migraine headache. Interestingly, many famous people, because it's so common, have migraine and migraine with aura. It was understood that Vincent van Gogh had migraines, and the artist George Seurat also had migraines. You can sort of get an idea of these twinkling lights in Van Gogh's paintings that maybe he was also thinking about or influenced by what he had. And this George Seurat painting of this dappled vision is sort of what people with migraine can see. Migraine itself has several phases of an attack. It's not just an aura or no aura and then head pain. It actually has 5 phases. Some people, and not everybody experiences all 5 phases. There's a premonitory phase, and this is a phase that comes either before the aura or before the head pain starts, and it can present itself with symptoms. A person can experience fatigue, overwhelming fatigue before they develop a headache, or they can feel elated, like they're on top of the world before a headache may start. Some get food cravings of chocolate cravings or salty or sweet cravings. Some of my patients express that they start yawning uncontrollably before they get a migraine, or get very thirsty. Another part of it is some people get stiff neck before they start getting a headache, whether that's part of the premonitory phase or another part of migraine isn't clear. The second phase is when people have aura, which we talked about, and then comes the headache phase, where people experience the pain of migraine. Excuse me. And the symptoms of light and sound sensitivity and nausea. People with migraine also get an activation of a different type of nervous system called the autonomic nervous system, where they can actually get teary eyes, red eyes, stuffy or runny nose with a migraine attack. And also people tend to want to avoid activity. As that pain starts to fade, this is called the resolution phase. People start needing sleep to help finally get over the pain syndrome. And then at the end of all of this, there's the post-traumatic, where some people describe this hangover feeling after a day or hours of a headache, where they feel either they may also feel very hungry and ravenous afterwards, or feel even elated once the attack is over. Migraine is, I want to talk a little bit about why people get headaches. You know, pain is supposed to be a warning sign that something dangerous is happening, but with migraine, it's not that there's something dangerous occurring within the body. It's sort of a brain misfunction and misfiring, creating these painful episodes. First of all, it's an inherited disorder. If you have one parent with migraine, you have about a 50% chance of getting migraine. If you have 2 parents with migraine, you have about a 75% chance of experiencing the disorder. And it's mediated by the central structures in the brainstem. Can you see this pointer on here? There's an arrow here. It's not very light. I don't know if you can see that. Okay, so we don't have a pointer. This is sort of a cartoon of the brain. And what's happening in a migraine, I'm just going to come around here so I can point out some areas. If we think about this being the front of the brain where the eyes are, and this is the back of the head, this would go down to the spine and the neck. And what happens during a migraine attack is that this brain stem, which is the structure deep in the brain, gets activated by triggers, whether they're external or internal triggers, and that creates these signals that actually go to blood vessels around the brain. That creates changes in those blood vessels. Those blood vessels create more inflammation and send signals back to the brain stem, and then ultimately those signals get transmitted to the outer surface of the brain into the pain cortex, where you experience the symptoms of pain. So it's a very simplified cartoon, but it's a complex pathway, and we're fortunate to have the knowledge of this in the last 20 years because it's helped us develop new treatment paradigms, which I'm going to talk about later in this presentation. I want to just talk now about what migraine means to you. First of all, as I mentioned, it's very common, it's under-recognized and under-treated. It's the 6th most disabling condition globally when you look at the World Health Organization statistics, and a lot of that has to do with the fact that it is we consider sort of a lifelong disorder, even though some people outgrow it and it diminishes in later years. It affects people generally in the prime of their life, and the attacks can be so disabling. If the pain's not disabling, often the associated features of inability to concentrate can be so disabling and affect people not only in their day-to-day activities and missing activities, but also people are less productive when they have migraine attacks. If you look at the subset of people under 50, it's actually the 3rd most disabling condition globally. It affects over 30 million Americans. 50% of these people with migraine remain undiagnosed and do not have treatment, adding to the burden. 50% of migraine sufferers experience severe impairment in their daily activities or require bed rest. The other aspect of this is that migraine is a highly stigmatized disorder. Patients tend to underreport, and part of that I think is our natural tendency to get on with life and work through things. But I think it's also because of the stigma that people don't want to appear weak, or because it's not really appreciated that this is an inherited neurological disorder, not an emotional problem as it was thought of, fortunately a long time ago. Also, healthcare practitioners underdiagnose it, and a lot of that has to do with our medical school education, in that in medical school not many hours are spent to this very common medical condition compared to other disorders that doctors treat as outpatient. Also, very importantly, if you look at the unemployment rates in people with severe migraine, 10 to 20% higher than the general population. So it has a dramatic effect not only on the sufferer, but on their family. I'm sure many of you understand and get this, but the numbers, when we put them on paper, are a bit staggering. So let's turn now into how do you get control of these attacks? It's multifactorial. We want to talk about building resistance, avoiding triggers, and treating the pain. These are, I think, the most basic steps that you can start in getting control of your headaches and improving your headache frequency. And understanding that migraine is, we think about migraine, I showed you that picture, but really what it is part of, is this lowered threshold. So people without migraine have that same anatomy as we do with migraine. It's just that we have a lowered threshold for that pain pathway to go. So when we talk about getting control and things like building resistance and avoiding triggers, it's about making ourselves less vulnerable through lifestyle changes. So what are these lifestyle factors and building resistance diet plays a very important role. Hydration, there's debate in the literature about whether or not you really need to keep this hydrated, and I think for people with migraine, dehydration is a common trigger, so making sure that you have, it says 50 to 60 ounces of water daily, but if you're a petite person, that's going to be less, sort of half of your body weight in ounces. Caffeine is also a great mystery to people who suffer from migraines. They don't know if they should take it. They think it helps. Sometimes it triggers headaches. And actually, it's both of those things. It's a double-edged sword. A little bit of caffeine can work as a treatment acutely, but if you're using it frequently, it actually can start giving headaches over time. And some data shows that if you drink more than 8 ounces of caffeine a day, no matter what the source, that will increase your migraine frequency over time. So if you're a person who misses their weekend coffee and gets a headache, maybe you should evaluate slowly tapering off caffeine to see maybe that's part of your migraine trigger. If you are going to taper off caffeine in order to avoid a caffeine withdrawal headache, you want to taper very slowly and do a couple of month trial off it and see if it improves your headache frequency. If not, go back to enjoying your coffee. The other thing that's very important in diet is fluctuations in your main blood sugar level can trigger a migraine. So skipping meals, delaying meals is common, and also big quick fluctuations like having dump loads of high sugary foods or carbs. That quick up and down in blood sugar can be a migraine trigger. So making sure you don't skip meals, eating healthfully, having frequent meals with protein in each meal to give a nice even sustained blood sugar level. Stress is also a very common trigger. Stress is throughout our life. The day we don't have stress is the day we're not on the planet. Everything is stressful. It's a matter of whether or not it's good stress or bad stress. So how we manage that stress is really important. Thinking about planning your week ahead, if you know if it's going to be a stressful week, maybe making a strategy so you don't have this great buildup and drop off at the end of the week once the stressor's over that can lead to a migraine. And also taking time to decompress every day, whether it's through meditation or 5 minutes of slow breathing or through a hobby that you really enjoy. Exercise is also an important factor. Exercise builds your natural endorphins, and endorphins are your natural painkillers. So a number of patients who have frequent migraines aren't sure how to build that in because, as I mentioned, sometimes activity gives a migraine. So I would say exercise when you don't have a headache, although some people find it helpful, and do what you can tolerate, gradually building over time. And the last lifestyle factor I want to talk about is sleep. Sleep for migraine is really about quality, quantity, and regularity. Everybody needs a different amount of sleep, but what's right for you is important to keep and to notice. And the quality of sleep is very important. So if you're waking up multiple times a night or find it difficult to fall asleep, speaking to a healthcare practitioner about strategies that you can implement to help improve that's really important. The other very important thing in migraine that I've certainly seen in my practice is that sleeping in or waking up early, sleeping in on weekends or waking up early on Monday is a common trigger. So trying to get up within an hour and a half of the same time every day can be very helpful in minimizing people who get weekend headaches or Monday morning headaches. And lastly, I just want to talk about triggers. There's a lot of questions about triggers. Fortunately, people like to be in control and think about ways they can minimize their headache frequency, and trigger avoidance is one of the keys to this. But there's a caveat to this, is that our understanding is that triggers may stack. So that means it may not just be, let's say, chocolate or a glass of wine. It may be the day that you've had a lot of stress, you're relaxing in the evening with a meal that may include wine, there's a weather front coming in, and you've slept in later that day. And it may be a confluence of triggers that are in place that actually ends up triggering the migraine. So if you can't identify a single trigger, just notice over time, like keep a diary to see are there stacking triggers so that you know if you're under stress or if there's a weather front coming in. Maybe that's the time you avoid that third trigger. So diaries are a cornerstone to understanding what's going on. They're there to help you, not to make you feel bad. So I say to my patients who are having headaches all the time, start with marking the good days so I can get a feel for what your patterns are. Let's now switch to treating the pain. First, I'm going to talk about acute treatment. We use that term acute for the medication or the approach that you use when you get a headache and you want to get out of the attack. In terms of medications, there are several options available. There is a class of medications called triptans. Triptans are migraine-specific drugs that were developed in the early 1990s, around 1992, with the first one being sumatriptan on the market, an injectable. There's now 7 on the market. They're in different forms. Some come in nasal sprays, tablets, melt in the mouths, injectables. And these can be very effective for people with migraine. They cannot be used in people who have had a stroke, or who have had heart disease, or who have uncontrolled risk factors for all of those things, like uncontrolled hypertension or uncontrolled high cholesterol, because they appear to affect blood vessels around the heart and could be a risk for a heart attack. But in an otherwise healthy person, they can be extremely helpful and have given many people a new lease on life since they've been introduced. Anti-inflammatories are medications that we use, things over the counter like ibuprofen, naproxen, Tylenol. And then antiemetics are an important cornerstone to treatment if you're experiencing nausea. Many people get nauseous with their migraines. Sometimes it's only mild, and they think if I can just get the headache gone, I will not feel nauseous, and yes, that's true. But one thing to remember is that part of what's happening when you're nauseous is that your gut is not absorbing medication well. So if you are treating early and you're feeling a little queasy, that medication is going to take a long time to absorb if you take a tablet form, and it may not be as effective. We know that to treat effectively, you want to treat early. You want to use a full dose that's most effective for you. We talked about addressing nausea if it's present early on. And if the headache is not going or gone after 2 hours or so, look at your instructions of your medication and redose. The other very important aspect to migraine and migraine treatment is that if you find that you're getting more frequent migraines, or your headache, you're taking your medication and it's recurring again, you need to speak with your healthcare practitioner to look for other treatment options so that you're really one and done with your medication, or as close to that as possible. We also know that using these as-needed treatments, if used more frequently than 2 days a week, can lead to more headaches. In fact, it's a very common cause of chronic headache, chronic migraine, which is the term that we use for people having 15 headache days per month or more. And I see patients like this in my practice. It's a common thing. They start getting more headaches. They start taking more over-the-counter medications or prescription medications, and before you know it, over several months, they've developed headaches more days than not. So if you find yourself in that pattern, it's very important to seek assistance with that and tapering off these medications and getting a good approach to how you're treating. So the last note and the last caveat that I want to touch on is narcotics and the butalbital-containing products, like the old brand names of Furacet and Furanol, are not drugs that we typically consider as first-line agents, and in fact we avoid them if people have no other option. Obviously we don't want to keep people in pain, but as a headache specialist, those are not something that we often prescribe. There's also natural ways that you can augment, you use alone or augment the treatment that you already have using hot or cold compresses. Some people find that just pressing their head can be helpful. There's actually anatomical evidence of our understanding of how that's effective. Ginger can help nausea for people, deep relaxation, abdominal breathing where you're slowing down your whole central nervous system can be helpful. And a number of my patients use topical oils or liniments or They might need to have a massage or sleep to get over the attack. Let's switch now to prevention. So prevention is the term that we use to institute a method to reduce the number of headaches you're getting, and prevention also often leads to better as-needed treatment or better response to the as-needed treatments. We generally recommend prevention for people who are experiencing 1 to 2 migraines a week or more, or where migraines are interfering with your activities. Maybe you're just getting 1 or 2 migraines a month, but they're lasting several days, and you're missing 2 days of activities a month. That's 24 days a year. That's a lot of time. And also if you're overusing your medication, so if you find you're in that position where you're using them frequently. So let's look at the prescription approaches that we have for this. There are oral medications that people can take and injectables. The main classes of oral medications that we use are anti-seizure drugs, including topiramate, which is also the brand of that is Topamax, gabapentin, of which the brand you may know is Neurontin. We also use antidepressants such as amitriptyline, which is a tricyclic antidepressant, and another type that also has good data, venlafaxine. Blood pressure medicines can also be used. Things like the beta blockers, such as metoprolol, propranolol, and timolol have been shown to be effective, as well as candesartan, which is another type of blood pressure medicine that also can be used. The calcium channel blockers aren't always as effective, but some people do respond to them as well. And then we have the injectable forms. I don't know if people have heard about using botulinum toxin or Botox for migraines. Its indication is for people having chronic migraine. That means they're having at least 15 headache days per month, of which at least 8 are migraines. So if you're getting 8 migraines a month and they're lasting 2 to 3 days, that's considered chronic migraine. It can be very effective. It was FDA approved in 2011 or 10. And it's given as a series of injections. It's injected any place the pain can be, in the forehead, temples, back of the head, neck, and shoulders. It's a series of about 30 shots that are given every 12 weeks. And it generally reduces migraine frequency by about 50% and at least 55% of patients suffering from migraine. So it can be a very effective treatment. Obviously, it's a more expensive treatment, so we typically like to start with the oral medications. And let me turn to this last group, these CGRP-MAbs. So that is calcitonin gene-related peptide monoclonal antibodies. These are the newest class of drugs that have just come out on the market last year. They came out, the first one came out in May of 2018. 2 more were to follow in this autumn of 2018, and they are the first migraine-specific drug to use as prevention. If you'll notice, we're using these other classes of drugs, including Botox wasn't developed for migraine. It was developed for other neurological conditions. And if I were to flip back to that diagram that I showed you of migraine and the pathophysiology or the underlying mechanisms, this calcitonin gene-related peptide, or CGRP, is very active during a migraine attack. It's an inflammatory peptide that's found in high volumes in people having a migraine. And what this does is it actually blocks those antibodies and also reduces migraine by about 50%. I think most of us in the headache community were hoping that as a new treatment it might exceed those treatment parameters. And some people in all of these treatments do get better, but we're very excited to see that we're now at the beginning of a new generation of migraine treatments that will target the specific mechanism. The advantage of that is that you will hopefully have much fewer side effects than these pills that get taken systemically. And if you end up going on a migraine preventative, and you're speaking to your healthcare practitioner about it, I just want to go over what you might expect. Typically, we start at a low dose because if we're using blood pressure medicines or seizure drugs, we're not treating you for those disorders. Often people respond at a lower dose, and we generally start at a lower dose, gradually increase the dose until you experience efficacy. And approximately 2/3 of patients will have a 50% in their migraine frequency over time as we use these. It's not fast medicine. It can take several months for a drug to work, and that first drug doesn't always work. But if you keep at it, you can really get significant control of your headaches. Also, when you're thinking about being on a preventative, speak to your healthcare practitioner about the pros and cons of the drugs. So if you have other issues such as sleep difficulty or depression or anxiety, which are very common with migraine, or if you're trying to lose weight, there are different drugs in these different classes that have these as side effects. So you can exploit those if you have high blood pressure. Maybe a high blood pressure agent's the right dose. Or using one of the other sedating medications, or again, if you have anxiety or depression. There's also devices for migraine. Pills and injectables are not our only option. There are 2 such devices currently on the market. Actually, there's 3. I don't have the third in here, but these are the ones that have been used for prevention as well as needed treatment. The advantage of devices are that they have minimal systemic side effects. They're not going to have drug interactions. There are some contraindications to them, but generally they're considered pretty safe, and they can even be used in pregnancy. The Cephally device is a transcutaneous electroneurostimulator, or a TENS unit. Some people may be familiar with them if they've had physical therapy for other injuries. You may use a TENS unit on muscles to help get better. Well, this is a device that's worn on the forehead for 20 minutes a day, and it can reduce migraine frequency by 50% in about 35% of people. And if you look at that data, about half of people had a 50% reduction in their as-needed treatments. This device actually comes in 2 modes, so it can be used as a preventative, but it also has another setting for some of the devices that you can actually wear it for an hour when you're having a migraine attack. And if your medications aren't working, or if you are sensitive to medications, or you can't take medications. The other device is this eNeura Spring TMS device. TMS is called transcranial magnetic stimulation. And in this device, you're getting a very small magnetic impulse that's sort of about 1/50,000th of what an MRI might be. And it's being applied to the back of the head. And there is data that shows that about 46% of people who were enrolled in these trials had a 50% reduction in their migraine frequency. It can be used acutely as well during an attack. These products need to be used for at least 2 to 3 months to begin to see benefit. And the downside of these is that they're often not covered by Medicare. And they are not often covered by insurance. So that's the device makers are always looking at ways to promote and give discounts, but just understand that they are certainly going to be more expensive than a generic tablet. There's also supplements that can be used. This is a busy slide, but basically there is pedicides or butterbur, riboflavin, which is vitamin B2. This is all in the handout that I have over here, including the lifestyle recommendations. So please help yourself to this. Don't feel like you're going to miss out if you don't take down the notes on these. Magnesium, an herb called feverfew, and coenzyme Q10. The one with the best efficacy is pedicides. The caveat about pedicides is that there have been reports of liver toxicity with this. So just because things are natural does not necessarily mean that they're safe. In the United States, using a sub-study using the brand, just looking at Pedidolux brand, and I'm not paid by their company, just, that has been the product of pedicides that has not been associated with any liver toxicity. So if you choose to go down that route with that, since it is something you can buy directly without a doctor's prescription, you want to make sure that you're getting a brand that has none of the toxic elements in it, and you want to inform your healthcare practitioner so they can follow your blood work just to make sure that you are safe on that. And the others are generally safe, except for I would just caution that feverfew and coenzyme Q10 may interact with blood thinners. So if you're on warfarin or another blood thinner, you may want to speak to your healthcare provider about the effect of those on your other medications. Turning now to complementary treatments. There are other mechanisms to treat migraine. Acupuncture can be very helpful. There's some data that suggests that it can reduce migraines by 50%. In my own practice, I haven't seen that great of a reduction. However, when it works, it can be very effective and reduce the need of medications. It can be costly because it's often not covered by insurance, and to really get its full benefit, it's best used if you do it once or twice a week for a 12-week or more period, and then gradually taper down the frequency of the use of acupuncture. Biofeedback is actually the treatment that has the best data on reducing migraine frequency. And if you look at where people are after a year of treatment and compare them to some of our first-line migraine treatments, actually biofeedback can be as effective. Biofeedback is a little bit complicated to explain, but this is a very simplified cartoon. Basically, you'd be with an instructor who's going through biofeedback with you, and you're attached to a monitor, and that attachment is either testing or checking body temperature, breathing rate, muscle tension, heart rate, and you can learn, they teach you how to change your physiology, how you're experiencing your muscle tightness, your heart rate, and breathing rate to change the image on the screen. And by doing that, you're sort of training and retraining your central nervous system, and that is raising your threshold and reducing your migraine frequency. It can be very effective in stress reduction. It can help anxiety and sleep. So it's really a great way, and it's very effective in teenagers too. Teenagers and children really respond very well to this method. And lastly, I'll just touch on briefly, cognitive behavioral therapy can be very effective. It's a very problem-focused type of therapy to help you deal directly and handle stressors. So as we talked about stress being one of the triggers, if you can learn how to handle your stressors, you're going to, that should segue into building your resistance against getting migraines. And then other modalities include things like deep relaxation, yoga, massage, physical therapy, particularly for people who are having a lot of neck and shoulder discomfort with their migraines. I want to switch now to when do you need to worry about a headache? Because we talked about pain being a warning sign. And there are some important, what we call red flags, or signs that should prompt you to seek urgent medical attention or quick medical attention. If you have migraines, but you notice that they don't feel like your regular migraines anymore, or they're getting progressively worse, or you've never had them and you're over 50, that's a sign that it could be a secondary headache. Headaches that start explosively or are the worst headache of your life prompt an ER visit. Headaches that are coming with a fever or a rash or a stiff neck, or with any other medical illness. For example, if you're undergoing any chemotherapy and develop a new type of headache, or you're any way immunocompromised, would be important to bring to the attention of your healthcare practitioner. If you have headaches that are brought on suddenly by coughing or sneezing, that's also a red flag. Or following trauma, if you develop a new headache type after head trauma, certainly seek attention. And finally, if your headaches are becoming more and more frequent despite the fact that you're taking medication, you certainly need to seek help. So just to wrap up, and then I want to open up to any questions you may have. Head pain is a very common symptom, and it's a symptom of many different types of headache disorders. The way that we give you a diagnosis is by your symptoms and thinking about whether they're primary or secondary. And the reason that's important is because your diagnosis leads to your treatment plan. Also, I want to emphasize that migraine is a real neurobiological disorder with an underlying mechanism that we're beginning to understand more and more about, and it's extremely disabling, and millions go underdiagnosed and undiagnosed. That lifestyle modification is really the cornerstone for all migraine treatment, and it alone can lead to the reduction of frequency and reduced need of as-needed medications. And I'd encourage you to work with your healthcare practitioner, or if you're not at that stage yet, to be equipped with a medication or a group of medications that allows you to be one and done with your treatment, so you're in control and that the migraines aren't impacting your life as much. And if your headaches are frequent or hard to treat, certainly get help. Be aware of the dangerous headache symptoms and bring those to the attention of your healthcare practitioner, and consult a headache specialist to learn about the many effective therapies that can be tailored to you so you can get control. Migraine is, for most people, a controllable disorder, and there are many treatments out there, and I encourage you to seek help if you're at all affected by this disorder. Thank you. I'd like to turn it over to questions. I also have these handouts, and we have a brochure up front which has our what we provide in our headache program here, along with our practitioners. We have since added a new practitioner I should say, has joined our group, Dr. Matt Robbins, who's wonderful. So we have several healthcare headache specialists at our institution, brochures out there. We can all be booked at the number that's on the top. If you have other neurological disorders, we also have information about our general neurology program here. Any questions?